common medication that you use for this is somebody who has like aplastic anemia. Okay, so if you have aplastic anemia, there's just a few things that we can give you. Erythropoetin. So epoetin. We talk about it. This is to improve your hemoglobin and hematocrit. We already talked about it. And basically, it's going to improve your blood cells. Because of the side effects, we got to stop it when we get to a certain level. We cannot keep on transfusing you forever. And we start when your hemoglobin is less than 10, okay? And then as soon as we get over 11, stop. And when we see hypertension side effects, we got to stop giving you to you. Expect patient lab work to show polycythemia vera, which is expected. But if I see headache, I have a priority patient. So I give you erythropoetin and you have polycythemia vera, your hematocrit go to like 60%. Yeah, that's expected. But if I see that you have headache, well, no, I don't want you to have headache because you're going to have stroke, PE, and thrombosis. And so that's a side effect of that medication. And so as you intervene, this is usually given sub-Q or IV. The second one is platelet. So if your platelet is low, the common drug that we can use to help with, I call them opera, so opravelkin. And this is going to increase your platelet. In addition, you transfusing them with pack of platelet. But this is very good. It has side effect. The common side effect is the cardiac side effect. You get cardiac dysrhythmia. So that's why you got to be careful with this patient. That's the side effect. But this is the medication you give it to a patient who has low platelets to improve their platelets apart from you transfusing them. And then the side effect is cardiac dysrhythmia. It's very straightforward. The other one is the white count. If your white count is low, well, we give you I like them, they are grastims, I call them filgrastim. So they have, this is their last name. Example is the pigo filgrastim. So this is going to increase your WBC. So you should expect they will have leukocytosis. Somebody, WBC is like 2,000. You give them, it will be like 20,000. That's okay. You expect that because of the medication you're giving them. The side effect is usually bone pain. Bone pain is the common side effect for this medication. Okay. And then the other ones, you guys already know them. We're going to go over them briefly. I think we've done them multiple times. It's warfarin. Okay, these are part of it's cardiology, but at the same time it's hematology, which is spumating. It's anticoagulation. It's going to block factor 2, factor 7, factor 9, and factor 10. And it's going to change, and sometimes protein C and S. What it's going to do is going to increase your INR and your PT level. Okay, and we want your INR to be 2 to 3, right? And your PT to 16 to 25. This is the level we want it to be. If you're taking this medication, this is where you want to be. Remember, these are oral medication. And what? You got to teach the patient bleeding precaution. I've said this multiple times, and you heard me say it. Well, take the rags from the floor. Use electric shaver. Okay, you see black tarry stool? No, it's bad. No NSAIDs, no aspirin, right? Your toothbrush, yeah, I can list them. Bristol toothbrush, right? Avoid any, or just have like a bracelet, okay? A lead bracelet. As much as possible, have it on your body. And this is the key, okay? They always put in the question. Okay, I'm going to put asterisks around it. I know I'm going to block these factors. These are vitamin K dependent factors. Okay, they are vitamin K. Oh, sorry, vitamin K. They are vitamin K dependent factors. Don't increase vitamin K. Don't decrease vitamin K. I want it to be same. So don't go and eat too much vitamin K because I'm blocking it, and don't stop eating them. Whatever you be eating, just keep on eating that vitamin K so that when you're bleeding, I know that it's me giving you too much coumadin, and if you get a clot, it's me not giving you enough. That's the teaching you tell them. So just whatever you know vitamin K, fresh leafy vegetables. That's what the question will say. So leafy vegetables. Don't increase it. Just eat whatever you eat every day as much as possible so that we are in the same level. But the coumadin is going to work. And then you avoid the 4Gs, the ginkgo, ginseng, ginger, garlic, all those crabs. That's the teaching you provide them. So these are easy. There's a diet problem, and you check their PTT. No, their PT level and INR. His friend is heparin. Yeah, heparin is different. There's an IV form and there's a sub-Q form. The sub-Q form is for prophylaxis. So this is the one they give you 5,000 units. This is to prevent 3 times a day to prevent DVT. This is prophylaxis. You don't need to check, do not check PTT with that. If I give you a drip, yeah, if you're getting a drip of heparin, yes, we need to check your PTT. And we want it to be within 45 to 70. That is normal as much as possible. This is where we want it to be if you're taking that medication. If it's high, we stop it. Its half-life is very quick, like 90 minutes. So you can stop the medication quickly. And if you have toxicity, we give you protamine. So these are like a quick review. Protamine, 1 gram. Just to add that, if you're bleeding from coumadin, I give you vitamin K. If you're bleeding from heparin, I give you protamine. Straightforward. What they will ask you in your question about heparin, they always ask is what heparin does. Heparin lower your platelet. And platelet are enemies. So we have something we call heat. Heparin induced thrombocytopenia. That means when you put somebody on heparin, expect your platelet to go down. That is normal. But if it happens after 4 days and is greater than 50%, even if 1 day and it happens more than 50%, you have to worry about it. So that's where you have to worry about. So usually your level is like 150 to 400,000. So anything below 150, start worrying that the platelet is low. So you got to, this is a priority patient. So heparin-induced thrombocytopenia. Usually We give you this medication to prevent you from what? Clotting, so that you don't form a clot and get stroke. Listen carefully. In heparin thrombocytopenia, is the opposite. Now that you heparin-induced thrombocytopenia, your platelet is too low that you start clotting now. Even though I'm giving you too much heparin so that you can bleed, your platelet is clotting now. And so your risk is thrombosis more than bleeding. So watch it. They have more thrombosis than bleeding. So this patient, stroke is their problem, or DVT is the other way around. I know I'm giving you heparin so that you won't clot. But if I lead to heparin-induced thrombocytopenia, now my major problem is I'm going to have thrombosis. I'm going to start clotting, and they have stroke. So you should worry more about stroke and DVT than bleeding. The question that they will ask is, what do you do then? You stop the heparin, stop the IV tubing. Most of the IV tubings have heparin in it. Okay, notify the doctor. They will need another anticoagulation that doesn't have heparin. So sometimes like Coumadin or the Zabans. Any other one that has Zabans as last name, yeah, that's your friend. Don't give them this boy. Okay, it's a trap. Okay, because it's a molecular, not Zaparin. It's a lower molecular heparin. So and no Zaparin. It's a lower molecular heparin. It's still an heparin. So this is still an heparin. It's usually given sub-Q. That's the only difference. So if you choose it as the next one, no. We're not going to give you Lovenox, which is enoxaparin. It's still an heparin, so we don't give it to you. The best way to give Lovenox, if this is the person and this is their belly button, you go 2 centimeters on the left side or the right side and inject sub-Q. You pinch it. If the people are a little bit big and you can pinch 2 centimeters, you inject it 90 degrees. If you cannot pinch, so if you pinch less than 2 centimeters, you inject it 45 degrees. This is fundamental. But 2 centimeters away from the belly button lateral is how you inject sub-Q for Lovenox and enoxaparin. Okay, so those are heparin and its friend, heparin-induced thrombocytopenia, what you do with it. The other friends, they are all anticoagulation. Before I go, don't get trapped. Heparin and enoxaparin, there's no diet issue here. You don't need to worry about diet, nothing, vitamin K, nothing. Don't worry. Don't eat. There's no diet restriction. You can do whatever you do. Okay. The other group, there are a bunch of them. They are factor 10, okay, inhibitors. So, like I said, there are 2 types. There are Gatroban and Zabans. This is where this is the only thing I think their first names can vary. There's so many of them. If I give it to you, then if you see something else and you don't know, you say, oh, I never saw this before. Yeah, but look at their last name. They are Gatrobans, okay, or Zabans. These are their last name. They are the same as any anticoagulation, the same teaching you provide, okay. If they give it to you, they tell you what is going to be used for somebody who is bleeding or has clotting problem, and you put them on it. So same teaching, okay. avoid bleeding precaution. So those are the bleeding precaution. You give it to them. There's no diet restriction as they're going to trap you. And then anytime they're bleeding, yeah, you tell them to avoid NSAID. I don't want to list them. They see black thyroid too, the same thing. To avoid aspirin, all of them are the same. Okay. Some of these medications are taken twice a day, like Eloquest, twice a day. And you got to stop it. Most of them, 48 hours, you stop it before surgery. Most of them, 48. They're very good quickly. They get out of your system. Okay, so that's the those medications. There's antiplatelets, and I'm not going to waste too much time, but I'll give you the best way to remember them. I call them ADAPT. Okay. Okay, the first one is aspirin, which we already know. They are antiplatelets, so they're going to decrease your platelet and make you bleed. Therefore, if I give you aspirin, expect platelet to go down for 7 days. That's how they block them. So if you're going to have surgery, stop it for 7 days. Before 7 days, what do you do? Teach them bleeding precaution. The same thing. Okay. The D, okay, they are fancy name. I don't know. I can't even say them. But if they give it to you, you know that this is antiplatelet. They look weird. And the A is the map, say abscissimab. That one is another one, antiplatelet. The same thing. They do different mechanism, but they're going to decrease your platelet level. The one I want you to know is P, the other P, which is the Plavix. But this is the name they will write. Okay, clopidogrel. That one you have to know it. Clopidogrel is antiplatelet. The other name is Plavix. It does the same thing as aspirin, but different mechanism, the same precaution, the same teaching that you give to the patient. And the other one is Tyclo, like you see. So if you see answer choice and it doesn't follow ADAPT, yeah, that's one of the antiplatelets we're talking about. And see, and the last one is thrombolytic. Okay, that one is a clot bastard. All these are stabilizing the clot, especially the heparin and the coumadin. And the last one is the thrombolytic. We've talked about them before. This is like breaking the clot. They burst it. And so they are high risks of bleeding. They are number one. They make you bleed, 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 and you have to be careful of them. I mean, this is what we use, like if you have stroke or if you have heart attack within a certain hours, we have to give it to you. And the last names are all place or lace, whatever you want, whichever you want to do. At the place. So you can recognize them with the lace as their last name. As soon as you see it, you know it's a platelet. It's a thrombolytic problem. What I want you to know is contraindication. This is where they will get you. There's some patients who cannot get this medication because it's going to cause you to bleed a lot. So uncontrolled hypertension. Yeah, you can get it. If you have recent surgery, no, you can get it. If you have atriovenous malformation, that means your veins and your atrium and your arteries are together. If this is the vein and the arteries are here, so they're together. So you have like a look like aneurysm, but they have malformation. This can bleed easily and they can rupture. Yeah. So 1, 2, 3, they cannot have it. And then recent head injury. So you have to know these 4 contraindications. Uncontrolled hypertension, we're talking about systolic like 190, 200 range, and diastolic really high. They just had surgery within 3 months. They have recent head injury within 3 months. Yeah, they cannot get thrombolytic therapy. Okay, and this is the end of yeah, it's the same as TPA. Yes, that's TPA. Yeah. And this is the end of it. Thrombolytic hematology is dry, but there's a lot of information with some farm, and so we will do some questions. And what is AVM? Atrial. So yeah, let's see. So you have the artery and the veins together. So you have you call it atrial venous malformation. That means the artery and the vein are joined together in certain way and they are more formed. And so they dilated and they can bleed easily. So AVMs, they bleed, they are the common cause of bleeding. And so these patients need to be off. They cannot get thrombolytic therapy with that. If you have stroke, usually between 3 to 4 hours, I think they went up a little bit, 4.5 hours, you can get it. MI within 12 hours, you can get thrombolytic therapy, but this can be dangerous. You have excessive bleeding, so you got to watch these patients carefully. And that is hematology, dry hematology. Any questions?